Hello, good afternoon, everybody. Can you hear me? I'm hoping you can. My name is Claire Coughlin. I'm clinical lead for Bowel Cancer UK, and I'm absolutely delighted to be with you this afternoon to bring to you the evolution of pelvic exenteration surgery bite-size event. This is the third of our bite-size events that we've held this year, and I'm particularly thrilled about this one, as I myself work in a trust where we don't offer pelvic exenteration surgery, but we do refer lots of patients to trusts that do offer this as a service. So for me, it's fantastic to be getting information about what our patients are going to experience and what they're going to be going through, and the care that you will take of them in the centres where you offer the pelvic exenteration surgery. Now, I know there are lots of people from those centres that are also joining us today, and I'm sure you're going to really enjoy the three expert speakers we have this afternoon for you. Before we get to that, just a little bit of housekeeping. So the first thing to say is that we have a chat box. I can see many of you have found it already because you're already introducing yourselves. If you haven't, if you're not in full screen, it'll be down on the right. If you are in full screen, then you can use the chat icon and it will come up somewhere in the middle of your screen and you can move it around. Please do introduce yourselves, tell us who you are, and we'd be delighted to say hello. The other thing is to say that we have a Q&A box. We will be having a question and answer session at the end of our three speakers, so when all three speakers have finished. But please do put your questions in the Q&A box as we go through. So anything that occurs to you, please put them in there. Again, it's at the bottom of your screen, or it'll be in the centre when you're in full screen. Put your questions in there and we'll get to as many of the questions as we can at the end of the session. Today's session will be recorded, and we'll be emailing you the link to the recording in the next couple of weeks. So you will have a chance to revisit all the information at your leisure, or just share with if you wish to. And the other thing to say is that we will, after the event, we will be emailing you an evaluation survey. That really helps us to know how useful the session has been and what we can do to improve things. So it would be great if you can fill that out for us, please. And hopefully it will also be helpful for you, because we will then send you a revalidation certificate. And just to say that we won't send that until the evaluation survey is closed. So that will be after the 27th of July. So if you fill it in tomorrow, you won't get the survey still until we close the evaluation, but it will come to you. So don't worry, you'll definitely get it. Okay. So before we start, we've just got a couple of little polls that we'd like to do. We've got a fabulous tech crew in the background. So here's the first one, and they've flashed it up for me, which is great. So the first question is, where are you joining us from today? Now we've got the 4 nations up there. I have a feeling that there might be people that from further afield as well. I know some people from further afield had registered, but we've got a lot of people in England, I can see. That's great. There's lots of you on today, so that's fabulous. Scotland, Wales, nobody from Northern Ireland yet. But we've got 3 of the 4 nations covered, and I think there might be people from further afield. If anybody sees that there is, then that's great. Let me know. Okay, that's great. Thank you. So we've got another poll that Richard, I think, well, yeah, here he is. He's fabulous. He's our tech crew. Thank you, Richard. So how many of you are watching? Are you on your own? Are there 2 or 3 of you? Got some friends? It's very hot if you're in a crowded office. I hope you've got the window open or a bit of aircon. Okay, so lots of you on your own. A couple of you in pairs. Two with some good company. 4 colleagues or more. Lovely. Okay, that's great. And then one more poll that's a first for us. We would just like to know, please, which social media platforms you use for your professional work. So hang on, we've just skipped a poll there. I don't know if Richard can get back to the poll about social media. Yeah, there it is. Can you tell us which of these you use? It's just useful for us to know when we're trying to get information to you. Okay, so a lot of you use Twitter, Facebook, a few on LinkedIn, Instagram, and some don't use social media. Fair enough. Okay, right, that's great. That's really helpful for us to know. A lot of people use Facebook. Very good. Okay, thank you. Right, so now to the crux of the matter, pelvic exenteration. So just before I introduce the first of our excellent speakers, I would just like you to tell me how confident you feel this afternoon in your knowledge and understanding of pelvic exenteration. So before our excellent speakers have said so much as a word, how confident are you feeling? So some people not confident at all. Okay, not at all confident. A few who feel very confident, and that's great. Okay, so hopefully by the end of the session, we'll all be going down towards feeling a lot more confident. So that's certainly the aim. But I've known patients that have had pelvic exenteration, but I would say I'm certainly at the end of not that confident. So I'm really looking forward to this. So without further ado, I shall introduce to our first speaker. We're delighted he's been able to join us this afternoon in what is a very busy schedule, I know. So our first speaker is Mr. Ian Jenkins. He leads the complex cancer service as a consultant colorectal surgeon at St Mark's Hospital. He's also the chair of the Association of Coloproctology Advanced Malignancy Committee and chair of surgery. He's a fantastic speaker, and I'm delighted to introduce him to you this afternoon to talk about the evolution of pelvic exenteration surgery. So over to you, Ian. Thank you.
Thank you very much for that kind introduction. Good afternoon to you all. I really am honoured to have been invited by Bowel Cancer UK to discuss an area of cancer practice that, for those of you involved in it, is a bit of a labour of love. And for those of you who are not, it's an area of great mystery, suspicion, and scepticism. And I'd like to talk to you about how this area of cancer practice has evolved over time to the present day. As you've heard, my name is Ian Jenkins, and I'm a cancer surgeon with a colorectal background with an interest in advanced and recurrent colorectal, mostly rectal cancer, and other pelvic weirdness. I'm based in St Mark's Hospital in London, and I lead the complex cancer service there. I'll just move the slides on. I have no conflicts of interest. So what exactly am I talking about when I say pelvic exenteration surgery? Well, what I mean is a variety of surgical recipes that we can mix together in different ways to optimize the chances of a complete resection of a pelvic malignancy. And the recipes can extend throughout the components of the pelvis, from the numerous soft tissue structures, or the viscera, as we call them, to the major blood vessels, the major nerves, and even the bone and muscles and beyond the pelvis. And there are different categorizations according to what we remove. It can be a total pelvic exenteration, or it can be a partial pelvic exenteration. And we can add other bits to that as well. Partial exenterations can be posterior, when we remove, for example, the rectum and the gynecological structures in a woman. It can be anterior exenterations when it's mostly the bladder and uterus that we move, the front bits essentially in the pelvis. But that's just the soft tissue in the center. And we can go out further. We can go out to the back of the pelvis and remove the bone at the back, the sacrum, either at low levels or high levels. Or we can go wider out to the sides of the pelvis, taking the bone of the pelvis, going wider, even taking the hip joints, and sometimes taking the whole half of the pelvis, called a hemipelvectomy. So there's a multitude of different combinations that even us apparent experts can't agree upon what the best terminology is to use. But we're trying to standardize all of that, to try and make it better, use the jargon more efficiently. This sort of surgery is generally performed in specialist centres and can be used for a variety of different pelvic malignancies, from gynecological cancers, such as cervical cancer, ovarian cancer, or endometrial cancer, to sarcoma surgery and urological cancers as well. And it will usually involve a variety of different surgical specialties: colorectal surgeons, neurologists, gynecologists, orthopedic surgeons, vascular surgeons, and importantly, plastic surgeons. And with that, there is a multitude of different specialist support services, be that specialist nursing, specialist physiotherapy, nutrition teams, critical care teams, and very importantly, specialist anesthesia. For most of our patients, they will have a locally advanced or locally recurrent cancer, and we assess where that lies in the pelvis in relation to all the other structures within the pelvis. And we imagine it a bit like an egg yolk and an egg white. The egg yolk being the tumor that we're trying to target, and the egg yolk is a bit like the rind of healthy tissue around which the tumor, we must cut around to get the tumor out, to get what we call a pathologically clear margin. And it's this clear pathological margin that is crucial to achieving a successful outcome. And that is not only related to what we call overall survival, but it's also related to disease-free survival. So it's a really important target for us exenterative surgeons. And to get that margin, our radiologists draw a dotted line around the imaging, around the tumor, and they give us a route that tells us where to go in terms of the surgery, which we call the surgical roadmap. And we establish that before any form of surgery. And if we stick to that roadmap, then we will usually obtain a complete clear surgical margin. And by doing this, by having this approach integrated with our radiologists, we start to see rises in what was originally very low levels of complete resection. We use the term R0 or R0 to significant increases in all of that. Our own R0 rates are reaching 85 to 90%, which is a substantial change. But in broader terms, who is it we should choose for this sort of surgery? Well, we consider three important factors that merge to give us the sweet spot from which we choose the patients to operate upon. One of these being patient fitness. They've got to be fit enough. They've got to be able to get up 2 flights of stairs before we would even contemplate them for such invasion. We've got to contemplate tumor biology. That's a far more nebulous term, far more difficult to determine, but there are surrogates in terms of the time from diagnosis, time from recurrence, or time to recurrence, for example, and also other factors in relation to the molecular biology of the tumor that we sometimes take into consideration. And then the third aspect is what we call the resectability. How easy is it to remove it? What will be required? And how extensive will that be? And will the morbidity associated with that be acceptable to a patient? And within that set of that Venn diagram, we find the sweet spot from which we choose our patients. But the most important aspect of all of that is patient choice. And we spend a lot of time with our patients, educating them, informing them as best we can to make sure that they give the most informed level of consent they can have, given the magnitude of the mutilation that we might cause. And we do this with different things like 3D reconstruction, there's patient education material, which may be alluded to later. We use patient interview videos of previous patients who might outline their journey. And we use many more adjuncts to try and simplify the understanding of what this all involves. And as we push the boundaries of what is acceptable, both in surgical and oncological worlds, we see more and more patients being considered for such interventions under this banner of pelvic exenteration surgery. Excuse me. So how did we get here? Or should I say, where have we been? Well, we need to go way back to the early post-World War II years, to the Memorial Hospital in New York, to a surgeon called Alexander Brunswick, who in 1948 was the first to really report what he described as pelvic exenteration surgery. And this was for a group of patients that were for palliation for locally advanced cervical cancer, patients that did not have metastasis, but had locally advanced disease with intractable, terrible symptoms. At the time, he was heavily criticized for putting patients through apparent mutilations, even though they appeared to produce some benefit to patients. And it took a long time for him to convince the surgical community of the value of this intervention. And like most apparent pioneers, he wasn't alone. There were other surgeons. There was Eugene Bricker in Columbia in the States. We started doing this in the 1940s, but World War II prevented him from reporting his results. There's Jesse Thompson in Dallas and Chester Howe in Boston, and they were performing what they called complete pelvic evisceration for locally advanced rectal cancer. That was in the 1950s, early 1950s. There was Lyon Appleby in Canada, in Vancouver, who performed what he called a proctocystectomy in 1950, and Edgar Brintsnell and Reuben Phlox in Iowa performed what they called a pelvic viscerectomy, again in 1950. Now, what is clear is that other than North American surgeons having pretty ridiculous names, a lot of what has been contemplated in that time is that we could offer more radical surgery to cure or potentially alleviate symptoms of patients with locally advanced and extensive pelvic malignancy. But you've got to be aware at that time, 5 out of the first 22 patients of Alexander Brunswick's died in the immediate perioperative period. And I'll quote you one of the things that was said about his practice or his operations in this area that's interesting, and it's still something that is a prejudice that we encounter to this day. And that is, it described the surgery as a thoughtless form of mutilation with limited chance of success for palliation, much less cure. And I still hear that nonsense paraphrased to this day, and it has been one of our biggest battles to change, that we continue to fighting increasingly successfully, to change entrenched dogma within surgery and attitudes about what this sort of surgery incurs. What I want to also say is Brunswick's first patient had a disease-free interval of, wait for it, 42 years. His later series would actually attest to the better outcomes with more experience, and this increased the acceptability of using pelvic exenteration, not only for cervical cancer, but also for other locally advanced pelvic malignancies. But we've even used it for benign diseases. There was an era when severe radiation necrosis of the pelvic organs was a problem, and we used pelvic exenteration surgery to salvage that successfully. And as we got more and more ambitious, we started to look at incorporating other aspects of pelvic surgery, such as bony excision, pelvic bone, to improve the surgical margins. It was another surgeon, Harold Juanibo, another fantastic American name, in the 1980s that was evolving the technique of what is called en bloc sacrectomy, despite the apparently really bad results of the initial experience of Alexander Brunswick. And more units started to develop these bony excision techniques with better and better results. And indeed, that's been one of our areas of specialist interest in terms of major bony excisions for recurrent rectal cancer. And with that, we've been able to challenge, our other surgical specialties, leaving with them with increasingly large holes, with which the plastic surgeons have had to come up with increasingly inventive ways of filling them. So as the general surgeons have improved, the orthopedic surgeons have improved, and the plastic surgeons have improved too. So the big question is, in all of this, all this effort for patients and cancer teams, does it actually work? Well, yes. Why on earth would we consider doing this or put patients through it if we didn't think there'd be benefit? And we need to understand this in light of what in terms of if we choose to do nothing, what would the outcome be? We know that the average survival for recurrent rectal cancer without intervention is less than a year, 6 to 9 months. And of course, you can add chemotherapy, you can add radiotherapy, and that might add some months to survival, but it's not unless you apply significant surgical invasion with a complete pathological excision that will give you the best chance of long-term survival, both overall and disease-free survival. And as we plan our patients better and increase our R0 rates, I think we will see better outcomes over time. And as we manage the morbidities, increase the survivorship issues and manage those better, I think we'll see this area to continue to improve. Failing to prepare in this patient group, however, will mean that you prepare to fail with these patients, and planning is crucial before any invasion. Integrating newer systemic chemotherapy, irradiation techniques, re-irradiation techniques may also form part of a better multimodality approach to these patients. So where are we going? So there are certain no-go areas for the surgeon that have been traditionally avoided. These are the areas in the high sacrum and areas extending out into the pelvic sidewall for pelvic malignancy. The pelvic sidewalls, as we call them. And then these were areas that were formerly regarded as absolute contraindications for any form of surgery. But it's interesting how things have evolved from the absolute contraindications becoming relative contraindications, and those relative contraindications becoming part of a routine in specialist practice. And indeed, there are techniques specific to what we do in St. Mark's that we've developed that are novel and have become evolved into routine surgical practice. We're taking surface of the high sacrum called a hiss to avoid total sacrectomy. We're doing high and wide sacrectomies for the most locally advanced cancers, rectal cancers that we see. And we've extended into the pelvic sidewall with a technique called ELSI to try to remove disease that extends wide into the pelvic sidewall, an area often associated with poor surgical outcome, poor resection rates, complete resection rates, and we're able to change that significantly for the better for our patients. And in all these areas, detailed, high-quality, systematic radiology has facilitated the technical surgery and optimized patient outcome. We're using three-dimensional simulation of each individual patient, reconstructing their pelvis to elucidate and educate the disease for patients, our trainees, and actually to better plan our own operations. We're even using more and more minimally invasive surgery, laparoscopy, and increasingly robotics for the more straightforward exenteration procedures that we're doing, and we're learning what is feasible within that area. Morbidity remains a problem, but it's becoming better managed, becoming more standardized in how we approach it, and we're seeing reductions in the impact to that upon patients. So what would I reflect upon? And these are my own opinions in this area over many years of good and bad experiences. As I said, for many, this is a labor of love. And it is one of the most contentious issues that we have is how well this is funded. It is not appropriately funded. And the majority of hospitals that choose to do this do so at a significant financial loss. But there is significant gain when patients individually are concerned. It is costly in morbid surgery, but when you consider factors such as the number needed to treat compared to most other oncological interventions, it outstrips them all. It is highly in its favor, and certainly far cheaper than many of the more elaborate systemic therapies and immunotherapies that are coming on the market. Morbidity still remains substantial, but they still live to get through that morbidity, and they cope, and the morbidity it becomes a thing of the past. Quality of life, we need far more data, but it does appear that most of patients will suffer a significant drop in their quality of life for the first 6 to 9 months post-discharge, but it does get better. And by a year after their surgery, it is not the same, but it's not far off the preoperative levels. How we can influence this, how we can better understand it, much more effort is required in this area. We also have to understand how we pick winners, our selection criteria, as we see more and more patients become suitable for this surgery. It's still crude just now, and we need to understand better predictive models, use better predictive markers, perhaps molecular, to explore that more nebulous area of tumor biology. That's much needed, and profiling based upon an individual patient's tumor is much needed, but still elusive. So it's an arduous journey for most patients from start to finish, and it's filled with much uncertainty and anxiety for over many years, even when we are seeing that they are likely to be cured. And more reach that destination of cure. And for those that don't, they still appear to live longer in general. It provides an opportunity to build relationships and clinical bonds with our patients and help them live with the highs and lows of living with these complex pelvic malignancies. But most importantly, I think it shows that we can learn how the boundaries of human spirit, how boundless that human spirit truly is. Thank you very much.
Thank you so much, Ian. I thoroughly enjoyed that. And as you were speaking, I could see patients that I've known that have come back to our care that have undergone this surgery. And so we won't take questions now, but just thank you for that fantastic summary of the challenges, but also the triumphs, and for leading this service, because I think it's so important. Now, without further ado, however, I am going to introduce our next speaker. I'm delighted that this person is our next speaker. It's Dr. Claire Taylor, who now is the Chief Nursing Officer for Macmillan, but also a Macmillan nurse consultant at St Mark's Hospital. She's been a nurse consultant at St Mark's for many years, and having supported patients having complex pelvic surgery for a long time. And we are absolutely delighted to have Claire speaking for us this afternoon. And she's going to talk about the specialist nursing contribution pre and post exenteration surgery. So thank you, Claire.
Thank you very much. Hello, everybody. It's really lovely to be here today. I wanted to talk about the insights that I have gained by working in the service with Ms. Jenkins, Ms. Burns, and all the colleagues in the Complex Cancer Service at St Mark's. I'm still there one day a week, and there is much I'd love to share with you. So I hope I've picked today some of the sort of key insights that will be useful to you in thinking about the, just go back. Sorry, just getting the slide control. The decision-making role that we have as nurses, how we can influence the prehabilitation process, which is about optimizing people's function and giving them the best chance to get to surgery and give them hopefully the best outcomes too, and getting them as fit as possible. And then some of the post-operative complications, won't be able to touch on all of them, but some that perhaps we find more challenging with this patient group. How we need to continue to support people. For many, it's a long process of rehabilitation. And in thinking about the evolution of it, I reflected on my 10 years in the role, having seen the service go from 30 referrals a year to over 300 last year. So what have I learned from that in a nutshell that I might be able to share with you? So you've heard already from me, and the decision-making is really important for this patient group. So we're talking about patients with locally advanced or recurrent rectal cancer generally. We do see people maybe with advanced colon cancer and other conditions in our service. But for the exenterative surgery, they've generally had some treatment at another centre. They've been referred in. And they may have already been through quite a lot of other treatments at the time of referral, but they're being referred to our service to think about whether they want exenterative surgery. And they may come with quite a lot of preconceptions, but quite often actually they don't have really much idea, and they're often very shocked at the first consultation to hear the extent of the surgery and really what it's going to require of them, the cost of it personally in terms of morbidity and that small risk of mortality. And they may feel that there aren't many other options. It may be that there is still some chemotherapy available to them. For some people, they may feel that they've exhausted all those options. So this isn't a process to rush. It isn't one that can be made in one consultation. And it really does take some time to get to know the patient, find out what really matters to them. So we're asking, what would quality of life look like for you? If we can get you through the surgery, what would good look like? What would be success? And for some people, it is all about survival. A third of the patients that we see are under 50. So they're really looking to live as long as possible. It may be that they have young kids and they want to see them grow up. And some of our patients, for sure, I'll do anything, go ahead and do whatever you need to do to get this cancer out. But perhaps somebody who's a little older, who maybe doesn't have any symptoms, doesn't really know whether they want to go through with possibly a 12-hour operation, 28 days in hospital, 6 to 9 months of recovery, because actually I'm feeling fine. The radiotherapy's done a really good job of treating my symptoms, and I just don't know whether I'm going to have enough good life afterwards at my age. This is often what we hear, to justify going through this. So we can spend some months indeed, discussing this with patients. And we've had a few patients who've sort of gone away and come back maybe a year or two later. So we always have to be really clear that it may be that now we can offer the surgery, as in we've seen on the scans that the disease is resectable and that we have a high chance of getting that R0 in mentioned. But it may be that if then, they go off and have a think about it, their disease is going to change, and it may be that in the future that surgical option isn't available. So it's really important that if somebody isn't sure, that they know there may only be a sort of certain time frame in which we can offer that. But while we were deciding, we're certainly looking at a host of factors in terms of thinking about, is the tumour resectable? What's happening to the disease biology? And how fit are they? And I think we've got better at assessing those factors. So it's a two-way process. We're telling them about the things that may be helpful for them to make their decisions and for their families, but also we're assessing whether they're going to be a suitable candidate, and we have a high chance of getting them through this successfully with a high chance of removing the cancer successfully too. So an important part of that discussion is about the impact on quality of life. And they do need to know that it's going to get a lot worse before it gets better. So you can see on the red line, these are the people who've had to get exenterative surgery. So at the first month, it drops dramatically. You know, people will be dependent, they'll have a number of symptoms, life is unpleasant. And at that stage, unless people have been properly prepared, they'll say, why on earth have I had this done? That's what we don't want to see. We don't want what we call decisional regret. We want people to say, I knew it was going to be tough. You told me it was going to be tough. But that they will know in their heads, because we've prepared them, that it's going to get easier. And week on week, sometimes it's month on month, they start to see the difference in energy levels, the difference in their independence and mobility, and they start to get back to the things that they get joy from and give them back that quality of life. But you can see that it can take at least 6 months. So many of these patients don't work actually for a year, but they may already not have been working. So there's an important consideration, particularly for those young people. You know, have they talked to their employees? Have they got the financial support that they need? And indeed, have they got a network of support around them to help get them through this? Because there's going to be a heck of a lot of journeys to and fro, care needs, practically, emotionally, socially, to get them through this journey. And I must admit, I really worry about people who I don't think have that resilience and don't have that social network. That's not to say that that wouldn't be a reason not to do the surgery, but we have got time to then work on that and build up the resources of that individual to help get them through. So making sure that they feel better connected, that they have the emotional support that they need. And one thing I'm really proud about that Bowel Cancer UK have taken forward is a pelvic exenteration patient support group on Facebook. And so patients are getting peer-to-peer support. And I think nothing beats somebody who's been through that experience explaining what it's like to go through this. And the feedback has been, it's been absolutely tremendous. We prepared some videos on our website that we share patients, and it's really hard to sort of gather a realistic picture of the variability that there can be, because as you've heard, there's so many different operations which we perform on such a large group of heterogeneous patients with all sorts of different things can go wrong with them. So there's no kind of typical recovery, but just to hear some of the experience of other people going through it, I think is worthwhile. So that's something I'd suggest to you. So I mentioned that the journey is complicated, and you may feel, if you're referring into a centre like ours, gosh, will they make their mind up and get on and operate on this person? Well, sometimes there is a deliberate strategy to see what's happening with the tumour biology, or we may be worried that this patient's at a high risk of distant metastatic disease, and so we may continue to treat them. And there has been a move in the last few years to a lot more upfront neoadjuvant therapy, making sure that we've optimally treated the patient, because we know probably in about half patients post-surgery who may be eligible for chemotherapy just aren't fit enough to have it after this massive surgery. So we're thinking about, have we explored all the oncological options with the patient? And so there's a backwards and forwards information discussion with the local teams. And you'll know, if you've worked with us, that we're always asking for more scans. But that is, a deliberate thing, making sure that the patient's clear of metastatic disease and their tumour in their pelvis is still operable. So we have a protocol that we'd only operate on scans less than 6 weeks old. We don't want to get caught out. The scans give the surgeons the roadmap, and that roadmap needs to be as fresh as possible to be absolutely sure we're going to get the best surgical outcomes for patients. But these are points at which I think the nurse has a really important role to play in thinking, is the patient up to speed? Is the referring centre up to speed? Are the teams sort of connected? So we're often joining the dots and making sure everybody knows where that patient is in that journey and that we've done everything that we need to do. We don't want to get all the way down to sort of surgery and then realize that we haven't done the functional testing or something that hasn't been thought about early on, because this journey can take months. You know, often referrals come in at least 6 months before we operate on them. And sometimes if they come in before they've had any treatment, we can be supporting them for a year before they get to surgery. So there's time to do all that important groundwork. Sorry, the slides seem to keep slipping. Oh. So one really good initiative, and I think Dr. Anne Williams is one of the participants today, is working on a decision-making guide and tested, but I think it holds a lot of promise for helping explain to patients some of the risks of surgery. And this can be a real barrier to people thinking about whether they want to go ahead when they get to that final stage and you're talking about the consent for surgery and they start to sort of stack up the possibilities that can happen. And here's a little pictogram showing that 20 out of 100 people will experience a major complication, which we can manage. You know, if we're an experience centre, we can manage most of these. It's the prompt intervention that's really key here. But giving these patients as much information and as much time to make the decision as possible is really important. And just one particular aspect of that, which is often a real stumbling block for many people in deciding whether they want to be exenterative surgery, is having a bag. Now, a stoma bag may have been cited as part of their treatment journey. So they may be saying, oh yes, I had an ileostomy before, I didn't get on very well with it, I don't think I can cope with that again. But for those people who are having a total exenteration and need both the bowel and urine stoma, so the urostomy, that may be for some a step too far. They feel they could cope with one, but they can't cope with another. But then you'll say, but have you actually talked to anybody about what it's like to have a urostomy? So really getting them engaged again with their local stoma care nurses and finding out what it's like. And again, that's where peer support is really useful, so that they're really making an informed decision about actually, do they think that they could live with that or not? And another aspect of pre-operative care that I mentioned at the beginning, that I think we've got better at in our service, certainly recently, because we funded Macmillan specialist physiotherapist and helper for 2 years, and that project has just finished. But we've sort of enhanced our understanding of what is needed in terms of prehabilitation. So enhancing the functional outcomes of people by getting them to the best possible place pre-operatively. And that is more than the personalised exercise programme that our physio Alice would put together. We actually broadened it out to involve our specialist anaesthetists and our pharmacists, and making sure that they were on the right medications. We'd optimise any comorbidity that they may have. The nutrition is increasingly important. So many of these patients are malnourished. They've really lost a lot of weight because of the chemotherapy. So we want to build up muscle. You know, we really want to think about the best diet to get them into the best shape. And of course, don't forget that there's that psychological component. And I think going forward, we'll probably involve more psychology input. But certainly, I think that the holistic needs assessment is a good benchmark for addressing any concerns that they may have. And there's a paper that our team have written, which you can see on the right, that tells you a little bit more about specific preoperative assessment guidance for this patient group. So just putting into a little table here, those sorts of steps. I've talked through the preoperative. So I've imagined them now that the patient's decided on surgery, they've been admitted. We prepare our list. Sometimes the big operations, particularly those where there is a bony excision, may be longer. The sidewall excisions and the high sacrectomies can take over 12 hours. So you can see why somebody would need to go into critical care for a few days afterwards. They then will return to the surgical ward. The length of stay for the more straightforward exenterations could be less than 3 weeks, but generally the length of stay is somewhere between 3 and 4 weeks. And if there is a complication, it may be that it extends over the 1 month period. For those people who were with us when they weren't able to have visitors, it was a very testing time without that psychological support from their families. If they're coming a long way away, so we have referrals from Ireland and overseas even, you know, discharge planning is no easy process, particularly if they have need for nursing care. We may be looking at nutritional support, additional wound care, as well as making sure that the stoma care provision is coordinated, they've got all their supplies, all their medications. But the particular requirement that keeps people in hospital is the rehabilitation. It's very difficult to get people to specialist rehabilitation units. So where we've done really extended resections and mobility has been impacted, the length of stay can be quite a lot longer. And that's why that specialist physio is absolutely vital. Without their support, these patients weren't being seen every day, whereas with specialist input, they're being seen once, twice a day and getting down to a gym. And that really makes such a difference to patients' confidence. And then there's that kind of acute convalescent phase where we need to be in regular contact. And there's a bit of a blur sometimes between teams, whether as the operating team, we're still involved after they've gone home, and at what point they return to the referring team. And in many cases, it's a bit of shared care, because if there is a manageable complication, it's best dealt with locally. But if it's something more serious, it may be, particularly if they're admitted, we certainly need to know about that. We want to help and support, and it may be we even want to transfer. So our MDT, quite often we'll be looking at scans for somebody who's perhaps been admitted with a pelvic collection, and we'll be making decisions about whether it needs draining or any other management, but the patient stays local. So we, as nurses in the team, we'll have quite a lot of liaison through those first few months to make sure patients feel that they know that if they're recovering well, that they're on track, reassuring them, sorting out medications, keeping them informed and updated, and making sure they have timely reviews, both with our surgical team and through their local MDT and the local team. So lots of nursing teams involved. And as we get through into the rehabilitation phase, you can see that there may be a need to think about some other issues, if we haven't already, such as fertility, menopause advice. We may be referring to urology nurses. It may be that patients had a catheter in, and then when we take the catheter out, they're unable to pass urine because the pelvic nerves are still damaged. So they need specialist urology input, and that's often of a nursing nature. We may involve palliative care, even if it's a curative resection, if there's particular pain issues. Stoma care obviously closely involved. Tissue viability will remain involved if there's been a perineal flap where there's prolonged healing, and a range of cancer nurses. So just a very crude criteria of at what point might we say somebody would go home, I suppose, would be that their blood tests are normal. And we want to keep an eye on those if there is anything abnormal. Quite often people have quite a high CRP on discharge, so we might be asking you to check up on that. If they've had a urostomy form, looking at their renal function, perhaps checking their HB. Often people's HB runs pretty low, so seeing if that's picking up. Checking that they can walk 50 meters and can do the stairs if they need them. Self-caring with the stomas understood. Eating and drinking, I've seen a question about that. We'll come back to that later. And pain, which I'm going to touch on.
Hi, Claire. Sorry to interrupt you.
Yeah.
We've just got about a minute left. I'm just aware we're running over time. Sorry.
Okay.
I don't want you to miss any because it's so interesting. But
okay. So those are the range of concerns that we may be addressing. And here's some of the complications that we'd experience in this patient group. And it's those longer term ones we tend to think about in our head, where the wounds aren't healing, a collection forms because you've got space in the pelvis. Fluid can gather there, and if it stays there, it may become infected and cause pain and discomfort for the patient. And managing the ureters, particularly if they've had a urostomy formed and there's been a narrowing of that ureter, we need to be kind of mindful and assessing that through close monitoring with renal ultrasound and CT with delayed urogram. So here's some of the pain that may be experienced. It can be really quite bad in the first 3 months. We often use a range of analgesics. People are often not already on opiates preoperatively. We use a lot of pregabalin if we know that we're going to involve, our surgery is going to involve nerve dissection or is going to go close to the nerves. So we start them on that at least a week before. And the anaesthetists are really good at using lots of nerve blocks. They'll use epidural and PCA. What we're not so good at is weaning them off afterwards. So if patients come home on quite a lot of medication, be thinking about that and how you can support them to come off that in time. particularly by 3 months. So there was a picture about the sacrectomy, and this is some of the data that we have. If we've done a high sacrectomy, we still get most of these people fully independent, so over 2/3 are needing a walking aid. And here's a picture of a man. I don't know how well it's coming up. Here it looks a little bit, but he's two days after an S23 sacrectomy on the ward, walking with his drip. And he sent us a video. This was 7 weeks post-op. He's out walking around in his garden. He can walk for 20 minutes after an S23 sacrectomy without a walking aid. So we tend to think about the people who've had the worst outcomes. I mean, this chapter's did fabulously. And there he is walking down. So I wanted to show you a perineal flap, and this is a patient who's still in hospital with a negative pressure on, and that's what the perineal flap can look like if we've done an eye gap. Those scars can heal quite nicely, and they have a slim buttock which from the outside won't show, but it can be really distressing for patients if they have to go home with one of these vac pumps on and lie, and manage that all day with a little pump attached to it. So we hope that we can get a good closure and prompt wound healing, and positioning is absolutely key to that, making sure people staying off that flap for at least the first 5 days. So a lot of that comes down to good ITU positioning and nursing care. So what have I learned? Well, it's not an easy option for many people. But it is often what they feel is their only option. But we want to make sure that as nurses and as part of a whole team that we make the best decision for them. Those who cope best, as I've said, are probably those who've had time to really make that decision in good time. They're mentally resilient, they've had the support, and they've had the rehabilitation I've described. And there's lots that we can do as nurses to bolster those resources and help them to get through that process. It's really rewarding having the long and involved relationship with these patients, but it can be quite draining. You really get to know your patients quite well, and when they go through difficult complications, it's quite disheartening. So it's vital that you look after yourself as well as getting support from your team through that process. Thank you.
Thank you so much, Claire. That was a great insight into just how involved this surgery is and the hard work that goes into all of this. So thank you so much. I'm just going to continue, if I may, to introduce our final speaker. We're delighted that she's with us. The third of our fantastic speakers this afternoon is Kelly Jones. She's a Macmillan Total Pelvic Exenteration CNS in Swansea. And she's been there for 13 months in this role, setting up the pathway, redesigning the pathway and supporting patients with decision making. I'm just going to read this very quickly. She joined Morriston Hospital in 1995 as a band 2. I think that's absolutely fabulous. And after 13 years, she qualified as a staff nurse and worked in neurology, where she had her first taste of pelvic clearance patients on the epidural unit. She then spent 11 years on the surgical decision-making unit as a staff nurse and a temporary junior assistant before embarking on her current role. I think that's a fantastic career pathway. Thank you, Kelly, and we look forward to hearing you now. Thank you.
Hi, and thank you for the introduction. I've been asked to share my experience of being a TB CNS with you today. I'd like to discuss what the structure looked like before I started, why I was put into the post, and how I've developed in the last year. The slides change. Next slide, please. Okay, so as I say, the agenda was just to look at what I did with this role, how I've evolved, and what's next. Next slide, that's it. So prior to my post, the patients for TP surgery would be seen by all these people that you can see on the screen there, but there would be no organised structure to the pathway. Oops. There would be no pre-op information other than the stoma nurses giving them what they need to know. They would have no prehab. They would only see the anaesthetist perhaps on the morning of theatre. They would be consented at that time as well. Follow-ups would be sporadic, and sometimes there'd be, you know, the patient would be chasing surgeons to see them. There was also no pelvic oncology clinic either. So why was the role developed? I was put into post to design the TP pathway to coordinate the care and for the patients before, during and after surgery. Hold on, somebody's pressing buttons. I was also put there to act as their key worker and to be able to problem solve any issues that arose and to make sure that the patients had informed decision making, to be sure that they were fully aware of the enormity of the surgery, to address any sort of psychosocial issues, and to liaise with all the people involved to make sure that the care pathway was coordinated then. Thank you. So as you can see, as a TP CNS, I liaise with all these people who are in this circle here. All these people are there to ensure that the patients get coordinated approach to their care every time they have surgery now. I deal with these people mostly on a day-to-day basis. Next slide, please. So the role evolved by I work very closely with a clinical fellow, a research fellow, Anwen. She developed a database, and that database was configured by her and another person, and I update that now on a regular basis. I make sure that nobody is missed, and then I keep on top of who's who and where they are on their pathway. I also have a patient surveillance database to keep a check of patients' scans, blood follow-ups, etc., and to make sure that nobody's missed. On commencement of this post, we started an oncology afternoon clinic, which was really helpful because the patients, as I said, never had that before. So now every Wednesday morning we have MDT. Then in the afternoon, then those patients that were highlighted that will need this type of surgery will come to that appointment in the afternoon. They will see the consultant, they'll see myself, and I will be able to get, they will be given a plan, they will be given results, and this is where I step in and I can help to counsel them. The stoma girls will speak to them as well. They'll be able to have a special booklet, a decision aid that Anwen also developed. This has gone down hugely well with patients to be able to make decisions on whether they want the surgery or not. We also discuss erectile dysfunction with the gents at this early appointment so that we can get that in as early as possible on the pathway and refer them, usually pre-op. I refer everyone I can to for benefits if they're not already in receipt of them. I identify the need for any transfusions as needed. This is because we've had issues with patients coming in on the morning of surgery and not being able to go ahead with their TP because their iron studies have been all to pot, and as you can imagine, there's a lot of money is wasted if surgery is cancelled on the day. I also do home visits. Sadly, I can't go to everybody, and I'll explain this in a few slides later because of the enormity of where we live. Obviously, I cover all of Wales. I am the only TPE CNS in Wales, so all our patients come to us down in Swansea. But I do try to visit those, especially those who emotionally need it. Anwen and the surgeons here have also developed a video which I've been part of that will go national at some point to help patients decide on whether they go ahead with surgery or not. We also have a patient questionnaire going out to see if you know, we're doing a good enough job, and it's always a success. You know, patients need that support. I have links with St Mark's in Southampton, and thankfully it was Claire Taylor that really helped to get my job up and running, and thank you for that. And, you know, they have been the support I've needed really to get the job going. So next slide, please. So as you can see, this is Wales, in case none of you know. We're always down the bottom in Swansea Bay, and my furthest patient is in Holyhead, which is nearly 5 hours away. I've also got patients who are on the Newport and Monmouth border. These actually come as overseas on my data. But, you know, I can't visit these patients, it's impossible. And for them, when they've got a VRAM and have DP surgery, this is sometimes impossible. So we do ask the colorectal girls in their areas to sort of keep a close eye on these patients. And I have started doing Teams appointments with them, those that I've got up and running, and that's really helpful. Next slide, please. So these numbers are low. This was my first year in post. As you can see there, majority coming for Howell Dda, which is actually down west, where there's a lot of farmland, which is interesting. The numbers for last year were around about 26 for the whole of the 12 months I was in post. We're only 6 months into my second year, or less than that, and we're already on that number, and we've already got 15 waiting in the wings to come in for TP surgery. So as you can see, we do have a lot, considering there was nobody doing this post previously. Next slide, please. So how have I developed? As you can see, the numbers are low, but they're growing year by year, and they've doubled from the first year I've started. So I've had to grow. I've increased my strength in many ways, to be strong for those under my care, to give strength in many ways, to be strong when they're having really bad news, but also, you know, just to be there and their support when they need it. I'm able to speak up to them for them when they need. To voice any concerns that they may have. It is difficult. Obviously, colorectal surgeons are a tough bunch, but I am the patient's advocate, and I do need to air their concerns and be their voice when I need to. When I say about EHA, so that's the holistic awareness. This is just helping patients to see, you know, what needs are needed by one patient and not needed by all. And I've tended to give these out before patients have surgery, and then at the end of their journey or post-op, so that we can sort of reevaluate things and see if things have changed. What do they need? What else can I help with? Next slide, please. So next we are, I started to meet the key worker session, so that would be starting September, where I have a clinic running aside the colorectal surgeon. There'll be pre-op patients there where I can get to go through the decision aid with them again. So there's a second appointment now to make sure that they're fully informed. I'll also be seeing post-op patients as well, so the consultant will be there as well in another room who can aid me where I need to flag up any problems. And when I say about GP education, obviously not all GPs need to know about the type of patients that we have with TP, but in some surgeries, they know nothing about TP surgery and when to flag things up to us. So those patients that in a certain surgery, I would educate them or send some information across just for them to be aware, you know, do they need to be going on pregabalin, pre-op or anything like that, if they're having any nerve issues, that they need to be sort of commenced on that prior to surgery. With regard to the prehab and psychological support, so obviously I've seen many gaps in the pathway. We desperately need prehab to be taking place now to get our patients up to an optimal level ready for surgery. There is no psychological support, I admit, and I'm not a counsellor, but I'll give all the support I can. I do refer on obviously to Maggie's and Macmillan and to Bowel Cancer and UK and everybody that's got that support network. You know, patients usually know who they're going to turn to, and I just advise who I think will be able to help them. I also think we need sexual counsellors, physios who are specialised. I know St Mark's have got that, and
Thank you so much, Kelly. That was absolutely fantastic. Thank you for that overview of your service, the brilliant work you've done, and for clearly being such a fantastic advocate for your patients. That was a great presentation. I really enjoyed it. Thank you.
Thank you.
Now, if it's okay, I'm going to go straight to the Q&A, if I may. We've had lots of questions in, which is great. I'll go to the first one that came in, which is from Marie, who's in Ireland. And she says, can I ask what your feeding protocols are post-exenteration, please? That's a good question. I don't know who would be best placed to answer that. That's an interesting question.
I'll maybe add in that. I'll start, and then maybe Claire and Kelly can add to that. I think for the biggest operations, the high, wide exenterations, we know that their gut function is probably not going to be working for some time. So we have a very low threshold for starting parenteral nutrition, and pretty much routinely do that in the biggest of operations. For somebody who's at a smaller and minimally invasive exenteration, we actually follow an enhanced recovery protocol whereby they actually fed in water pretty early on after the procedure. There's a reasonably high rate of postoperative gut dysfunction in the patient group because the small bowel falls into this gap where everything used to be. So it's not uncommon that they have a pretty good week 1, and then by week 2 there's a partial. And it might take a week or so to resolve, but we're often not sure about that and have a low threshold in that circumstance to commence them in parenteral nutrition. So I think if it's a big op, we would routinely establish TPN from the start. If it's something more intermediate or more minimally invasive, I think we'd wait to see how they get on, and if they have an established acute intestinal failure, start it then. Claire, Kelly, am I saying the right things here?
Absolutely.
Yeah, that certainly made sense to me. That was a good answer, and it's interesting actually because I suppose like the surgery, it's bigger but similar challenges. You know, colorectal. Okay, thank you. So we've had you partially answered this actually in your talk, but Jess in Oxford has asked, what can patients expect from the most localized to the most wide surgical field?
I think in terms of recovery, it's not so much linear, but there's a strong association with the magnitude of surgery and the length of the hospital stay. It doesn't always apply. Some of the people that get the highest or the most extreme surgery often do pretty well. But as a general rule, the bigger the operation, the longer the hospital stay. And within that hospital stay is related to morbidity, functional recovery being a bit slower, and the impact on home resource or the community sort of care, getting that all set up given the magnitude of what they may require. I will defer to Claire and Kelly for the rest of the stuff that might be said here, though.
I think one of the battles we've had in our hospital is about the variety of exenterative surgery. And if it's purely soft tissue and a young fit patient, they can be out of hospital in 2 weeks, and then we can be really well in 3 months. But as soon as you start dissecting nerves, resecting bone, and operations going over sort of 12 hours as a bit of a guide, you're getting into longer stays and longer recoveries.
Yeah. Okay. So that psychological preparation is so important, isn't it? As you said in your talk. Yeah. I think actually Kelly partially answered this, and I think that it's going to be a variable picture. But there's a question from Vicky: is there psychosexual support available to patients pre and post surgery?
No, there's not, unfortunately. I've got one ED nurse that will help patients with erectile dysfunction post-op. There's nothing really from the female point other than a physio does it down in Singleton. I refer on, like I say, to Maggie's, but really it's really a sad situation. I mean, even as far as like dilatation and things like that, it's something I want to sort of pursue and push, but it's usually the physios who are sort of doing this sort of thing. It's not really their place. It's just we are setting up something, and this is big on my agenda, so hopefully that becomes soon.
Yeah, and you've obviously done brilliant work already. Is there support available at St Mark's, Claire? Or is...
Better for the men. So we have a pathway through urology. We refer initially to our Medicare. We'll start medications. We sort of follow the Prostate Cancer UK guidance for managing pelvic cancers. It's much harder with women. We did have a pathway to the Marsden, and Isabel White has left. So it tends to be our plastic surgeon may see some of the ladies who've had vaginal reconstruction, or I do also signpost people to Relate, and they can go privately through digital health providers, or they can look up through the CORST, which is the Relationship and Sexual Therapists. There's a whole network of people who do offer some support, but again, that's private. So I think nationally there's poor services for this patient group.
Yeah.
Okay.
I think one of the things I would say, just as an anecdote, it often isn't manifest in the pre-treatment phase. There's a huge concern, and certainly in the first few months afterwards. But it's as patients start to get better generally, and as their quality of life starts to restore itself, these things start to become crucially important. And although they might put it off in the early pre-treatment phase, if you want to talk about it, say, I don't want to know, I don't want to talk about it, it's really important that you spend time talking about it then, because it will hit them within the first year. And for some of the young men, it's incredibly traumatic for them.
Yeah. Okay. Thank you. Okay, so there's one more question I'd like to get in, if that's all right, and then there's another couple of others, but I think we can probably pick those up afterwards, because I realised we're already 10 minutes over. So just one more, and that's about follow-up. How often do you see a patient in follow-up, either CNS or consultant, and is there a set follow-up plan? That's from Catherine at Adam Brooks. Who wants to pick that up? Who does the follow-up?
Claire does all the hard work, and we get all the credit.
I know that.
No. It's a real team. I mean, and it's very dependent on what there is locally and how the local team wants to play it, and how well the patient is and what they need. I mean, we often start with quite a quick follow-up within the first 2 weeks, seeing them within 6 weeks for sure, if we can face-to-face, if not on Teams. And then it will depend, but close surveillance for the first 2 years for sure.
Yeah. Okay. Is that similar for you, Kelly?
Yes. Obviously, depending on when they leave hospital, we try to see them within 6 weeks of the post-op period. Again, it depends how they are. Also, obviously, I'm lucky. I do a few home visits, those who need it, and then I have sort of brought patients back in to be seen, or bring them to hot clinics, if you like. There are some that don't want to come back at all, and that's because they are so young and they're doing really well. But within reason, 6 weeks, and then probably 2 months, 3 months, and then probably at least every 6 months for a year or two.
Okay. And just very, very quickly, I promise this is the last one, and we'll deal with the others afterwards. Are there any patients who don't qualify for? I think this has come from Lucy, who I know works in a hospital where we don't have this service, and she's asking, I think, about what we should be looking for when we're putting patients forward to you at the specialist centres. So who wouldn't qualify?
I think everybody qualifies for a discussion with the centre, and I think it's really important that, although it does generate a lot of work for the specialist centres, I think everybody should have an opportunity for a discussion. But if there's generally somebody incredibly unfit, or somebody who has untreatable or irresectable, but mostly untreatable metastatic disease, then that sort of patient category probably shouldn't be referred. But anybody else, I think we would want to take a view on them individually. Yeah.
Okay. Well, thank you so much. We will pick the others up after this. Thank you so much to all three of you. That has been eye-opening and interesting, and I certainly feel better informed. We've got a very quick poll, if we may, if Richard can get that up if there's still time, just to ask everybody how confident they are now in their knowledge and understanding of pelvic exenteration after this fantastic session this afternoon. It's a huge topic. Yeah, and everybody's knowledge has improved, and I'm really not surprised, because it really was very informative. So thank you so much to all three of you for giving up your time for us this afternoon, and it's been really helpful and will really benefit so many patients. So thank you. Just to say, Claire did allude to this. I think the Bowel Cancer UK slides are just going to come up. But just to say that we do have a Facebook group, as Claire pointed out, for pelvic exenteration patients. It's only been going a short while, and we have 25 patients already. The last time I asked about it. So please do encourage your patients to join. We know I've spoken to 2 patients who are on it, and they've both said just it's an absolute kind of godsend to them. It's really helped in terms of that really valuable peer support. So please do signpost your patients towards that group, because I think they may find it helpful. Otherwise, I think probably in the interests of time, we will just wrap up now, and it just falls to me to say thank you once again to all of you for coming to joining us this afternoon, and thank you to all our speakers for their fantastic presentations. Thank you.